Şimdi sırada Hollanda deneyimi için Doktor Beets var. Buyurun. Dr. Beets.
I'm working in Amsterdam right now, but I've been working in Maastricht in the Netherlands for over 20 years, so this is where our experience started. You will find my talk remarkably similar to the one that Pat Patey gave. We started in 2004. This was the year that Angelita Habergama published her Annals of Surgery paper. And actually this patient pushed me into starting it because he was referred to me from another hospital. They had seen this man with a distal, rather large rectal cancer. They gave him chemoradiation and the tumor disappeared. And the surgeon said, okay, nicely done, I don't feel anything anymore, so now next week you're having your operation and your stoma. And the man said, sorry, you're making a mistake. You're telling me the tumor is gone and you still want me to have my stoma. Yes, but the surgeon explained how it works. The man said, no, you said the tumor was gone. I actually referred to this patient as a sort of a colleague. He ran a large butchery shop. He was quite a sensible guy, so they tried to talk him into the operation. They sent him to me to say, you talk some sense into the guy because he won't listen to us. And I told him, well, there's this Brazilian lady who has patients like you followed up. I'm not sure we can believe her. I was quite skeptical at the time. But if you want to be followed up, that's fine with me. And this was our first patient, and he sort of was the start. He actually started our controlled series. So our current protocol is more or less the same. So we do assessment at 10 weeks. And we've added, as you heard yesterday, if it's not a complete response, so we're doing less local excisions, we added the test of time. We select mainly by finger, endoscope. Originally we started off with relying on the MRI for most part, but now we realize this is more important and we use MR to back up. We use diffusion and we watch at the lymph nodes. And then you sit down with the patient, you explain the risk and the benefits and the uncertainties. And our experience too is that if you explain everything, initially I had a lot of patients who interrupted me during my story and said, I get it, you've told me twice that there's a little risk here, but I get it, I'm taking the risk. So the selection, if you add everything together, you're quite good, but you're not 100%, because as Pat told you, local regrowth is an inherent part of the process. You accept that you're not 100% accurate, because if you can detect your persistence of tumor or regrowth early, so we should no longer call this salvage, but completion surgery. But if your surgery is still successful, then it means the regrowth is not a failure. So that's the change of concept. This is our follow-up schedule, the same tools. We probably do more MRI. If you're short of money, I would skip some of the MRs here, but I would still do the endoscopies. So this is the Netherlands, here is Maastricht. So we started here, and then the regional hospital started sending patients, and then one of the surgeons moved to the north part, and he was sending patients to the far south. Now we've moved to Amsterdam. This is an old slide because now we have patients from all over the Netherlands that were coming to me, but we're changing that. I will tell you later. So as in Pat's series, most of the patients were stage 3. So 2 out of 3 were node positive. We now have 287 patients. Most of them were distal. Most of them were after chemoradiation. But we accept any patient who has a complete response regardless of how they got there. Some of them had to stop the chemoradiation because of toxicity, but sometimes they still do have a complete response. We have patients short course and nothing, just a long wait. Okay, I have to stand closer. We also have patients after short course and chemotherapy. They're in the Rapido trial. We don't have the denominator, so our rough guess is that it's only 15 to 20% of patients who receive chemoradiation. So for the most part, these are large tumors with an accepted indication, and it's the pick the winner scenario. But we also see more and more patients with smaller distal tumors who say, well, the doctors told me I need an APR, but can I try the chemoradiation to try to avoid surgery? We have those increasingly in there too. So out of these 287, we have 264 that we watched and wait, and we have 30 luminal recurrences, 2 nodal recurrences, and 3 luminal and nodal combined. We have 7 patients with metastasis, and almost all of these patients had nothing to do with the local regrowths. Some had concomitant or earlier than the local regrowth their metastasis diagnosed. 97% survival. Well, despite that we've been doing this a long time, our mean follow-up is only 25 months because we keep on seeing more and more patients. But the survival is extraordinarily high, which is a testimony to the good biology of the complete responders. The local excisions, the ones who had a PCR, they did very well, too, of course. The ones that had residual tumor, they had more regrowths, as you can expect. 3 luminal, 1 nodal, 1 combined. They still do well, but they're a worse group. And most of these local regrowths were in the YPT2 group. So we generally advise these people now to have completion surgery, but half of them will refuse. So here's another example of a small luminal regrowth, and look at the interval. It takes a lot of time, and it's still very small. You could do a local excision, or you could do a TME resection. This is, as in the previous talk, the node didn't go away completely, but the radiologist said this is normal, but then it starts growing again, and then you do a TME resection. There's nothing there in the bowel wall, but there was a positive lymph node there. Another small luminal recurrence. And this is the one that it never turned completely normal. This is the one my wife likes to show, because at the diffusion there was a signal here, but we said, well, we don't see anything, so we don't believe it. But 11 months later, we biopsied this, and this was a YPT2 that was easily salvaged by a low anterior resection. So in our JNCI paper last year, these are the curves. The local regrowth rate at 2 years was around 18%, most of them in the first year, and all of them within 2 years, which is a little different from the Memorial Sloan experience. We could do salvage surgery in all patients, and we didn't seem to have any metastasis arising later from the regrowth, that is what you would expect if the regrowth would have caused a metastasis. We didn't see that yet. These are the figures from the updated figures from the 287 patients. The same, the 2-year local regrowth free rate is 83, so it's 17%. When we started off, we had about 10% regrowth rate, but now we're becoming more liberal, so I think we're now in between 15 and 20% regrowth rate. The distant metastasis rate is very low. And the overall survival is very high, and is also, not all these patients die because of metastatic rectal cancer. They also die of intercurrent disease. There is a very high interest of patients. We were surprised by the ease by which a lot of patients accept this little unknown risk and say, well, if I can avoid a stoma, I don't worry about a couple of percentage risk in the future. We'll see by that time. So this is a book from the UK of a patient, Saving My Arse it's called. This is my patient who wrote a book with a slightly nicer title, I guess. It's called The Emergency Exit. So it's become a bestseller in the Netherlands, and he is having a hotline from patients who said, oh, my doctor tells me I need a stoma, how did you do it? So he's having a show, and I was even on the show. I was sort of touring with him to give presentations. He has this thing here, that's his last Xelora pill. He's kind of a peculiar guy. He refused to take the last capecitabine pill as a sort of protest against chemotherapy. So, and he carries that around with him. Of course, patients do this for the functional outcome. Our 3-year colostomy-free rate is over 90%. In the Ranahan paper, this was slightly lower, 74%, but this is what patients like very much. And of course, retaining your rectum is not the same as having a functional rectum. So we did some quality of life questionnaires. These are kind of, difficult to interpret, but they do better than a comparable group who had a low anterior resection. It's not that they don't have any complaints, because when I see patients, they tell me, oh, I'm fine, doctor, no problem. And then they see the nurse, and then the nurse asks a couple of more questions, and they say, well, I do have to run a little faster than to the toilet than I used to. So radiotherapy does something. If you take the Lars score, I was kind of surprised to see that 1/3 of the patients reported major Lars as compared to low anterior resection patients. It's still a lot better, but it's not completely free of complaints. It's not a fair comparison, because these patients avoid a stoma, where in this other group, some patients end up having a stoma and they're not in the Lars symptom group. So the main complaint is that they say, well, I go a little more often and I have to go a little faster. I can't defer as much, but most of them are very happy with it. So what would you have to compare it with to convince the skeptical surgeon over there? We have been comparing, as everyone does, with the PCR, but as Pat told you, that is not completely fair, because in the watch and wait group there are patients too who don't have a PCR. But even if you compare it, it's 98% 2-year overall survival. This is from our meta-analysis group. That is sort of similar. You should do a randomized trial, but we asked our patients who had a complete response, would you be willing to take part in a randomized trial? And 9 out of 10, they say, no. I don't want to do this randomized trial. So we're not getting level 1 evidence. So we have the cohort series. And what we did was, we, together with Eureka and the Champalimaud Foundation in Lisbon, we put together, is everything okay? So we put together all the data in the International Watch and Wait Registry. We now have 38 participating centers, and we included 813 patients. There is some selection here, because I think surgeons put in their patients not at the first decision of watch and wait, maybe at the second decision. So there is a selection that is not in there. But what we see is reassuring, and it reinforces what the MSK series and our series show. The local regrowth rate here is 25%, the majority within 2 years, but not all of them. 15% have local regrowths later. And 96% occur endoluminally. So the big worry about the lymph nodes is a little exaggerated. So you can detect them. Too loud? Please, more loud. Louder. Okay. So the survival outcome in the International Watch and Wait Registry is shown here. The 3-year overall survival is 91% overall, and we're especially interested in the ones who get a local regrowth. It's 87%, but then again, only 1 out of 4 dies because of cancer. So how can you improve this by doing surgery on all of these patients? You can only improve it by 1 or 2% maximally, if anything. So in the Netherlands, we've taken this one step further because they were sending this to me, but now they're getting too many patients there, and we said, let's set up some, we don't want you to do this uncontrolled. You have to do this very well, consistent. Let's set up some regional expert centers where the radiologist is good, the surgeon is dedicated, and we're setting up about 10 centers. And when they have good candidates, they send the images to us of the endoscopy and the MRI, and we check on it and we give them the green light. And that's funded by the Dutch Cancer Society. So so we're going to implement it, and all these patients are going to be registered. We have another Dutch Cancer Society funded project. Still not good? Okay, I'll eat it. So there was a Dutch CART study and a UK TREC study on local excision for small tumors, and they have combined these into the Star Trek study. So they're going to take the smaller tumors you could do surgery only, and they're going to try to randomize these, and we'll have to see if that's going to work. Between the standard arm is radical surgery, and we have 2 organ preservation arms, short course and long delay, or chemotherapy and long delay. Complete response, watch and wait, near complete response, TEM, or even a further observation period, and no response, TME. So, and this is for the group of patients. This will tell us, so the winners and the losers, so how does that even out? So the quality of life in this is actually the main endpoint. Let's hope it runs. We're going to do another trial. If you do a local excision, a TEM on a small adenoma, you think it's an adenoma, and it's a rectal cancer with medium risk features, the standard advice is to do completion surgery, but they're going to be randomized completion surgery or adjuvant chemoradiation. This is another trial. It's another difficult trial for organ preservation for another group of patients. So these are things that we're discussing today. We'd like to increase the response. This is the to-do list. The role of local excision. We should look at the long-term functional outcome. These patients do better, but some have some trouble. Why is that? And prediction of response is becoming more important. So I'd like to conclude that organ preservation and watch and wait is feasible. After standard chemoradiation, it's only 15 to 20%, regrettably, but the big hope is that for smaller tumors, it will be much higher, and with the screening programs, we're going to see much more smaller tumors. But you need a good selection and follow-up, and if you do it well, your local regrowth rate is going to be 10, 15, 20%, and you should be able to detect and salvage patients early, and if any, the survival disadvantage is going to be very little, and this is very much outweighed by the high patient interest because of the improved functional outcome. Don't worry about the future role of the surgeon. We're going to do more completion surgery. We're going to do more of a coordinating role, less major rectal cancer surgery, and I think surgery, rectal cancer surgery, will be concentrated in less hospitals, so fewer surgeons are going to do more operations. But I'm sure we're still going to be happy surgeons. Thank you very much.